Community outreach is a really huge topic. Most providers have some kind of community outreach that they're doing. The sole exception within the healthcare space is probably dentists. Most dentists do not need someone going and trying to drum up community referral partners, whereas most other healthcare providers and service lines do. Generally, it's a very, very important part of the marketing mix. Sometimes when we talk about marketing, we only think about our digital channels or our traditional like TV, radio, billboard channels. Outreach is a critical component for most healthcare providers because the highest volume of their referrals are going to come from outreach one-on-one in the community from partners. And this makes sense. Again, when we think about where are patients going, for example, for a lot of healthcare providers that aren't hospitals, hospitals are a major source of referrals for most healthcare service lines. And that's because the hospital is attracting all of the sick patients that then need ancillary services or follow-up care. And so the hospital is that focal point, just like Google is the focal point for people searching online. So we always want to be thinking of what is our focal point? Where are our patients encountering our systems of care? Is it through nonprofits in the community? Is it through the education system? Is it through the justice department or the jails? There's a lot of different potential for where referrals might come from, and we need to have a good understanding of where our patients are going so that we can be talking to those community partners and then making sure that we're working with them to help those patients with the services that we provide. There is a lot that we could cover with business development, but again, this training is focused on broad overviews, understanding as executives that we have a basic understanding of the needs of the positions. When we go in and do outreach builds for providers, generally that's a multi-month consulting project. And so we're not going to cover that in an hour-long training. We're just going to go through the basics, the need to knows that are the most important. We always start with a territory analysis when we're thinking of outreach, and that territory analysis can be geographic, and that's generally the most common way that a territory analysis is run. We want to look within the community and say, okay, where are our referral partners? Where do we get the most referrals from? So we kind of understand it from a bucket standpoint. Again, is it the court system? Is it the hospitals? Is it senior care centers? Is it schools? Is it individual practitioners that are adjacent to our service lines? Whoever that is, we need to understand how many there are in the community, how big they are, and so what is the potential referral volume? And then we need other basics in there in terms of like what insurances do they accept and does that align with the insurances that we accept? If we understand those basics doing a territory analysis, then that's going to give us the information we need in terms of how many reps we should have, where those reps should be assigned. And then we can think about location as well as focus within the reps. So we might have just a territory focus, and we say, okay, look, this rep is going to cover the west side of the city. This rep is going to cover the east side of the city, or this rep covers this city. This rep covers that city, depending on how far you're pulling in patients from. Or we can do it bucket based, and we can say we have a rep that's just focused on public safety, which would be police, firefighters, court system. Then we have another rep that's just focused on hospitals. Then we have another rep that's just focused on the education system. There's different ways to structure the team based on the needs of your organization and the potential for referrals and how many referrals you need to be viable. Distance from home is one that we bring up all the time for clients in the healthcare services that pull from a wider area. Most healthcare providers are going to pull from like a 10 to a 30 mile radius for a lot of their patients. But some providers, especially if they're on the higher end or if they're providing long-term care services, they can pull from the entire state, up to 100 miles away, 200 miles away at times. Your reps can't cover that much territory. And so this is something that you really have to think through if you want to be successful. Because what we see happen a lot of times is we'll have one rep. We've seen this multiple times with some of these providers where one rep is assigned to the entire state. There's no way in hell that one rep can effectively cover the entire state. And then what's going to happen is two things that are negative. One, they're going to be spending a lot of time driving. you're paying for drive time. You're not paying for them to actually be getting in front of community referral partners. And so that's a really inefficient use of that labor cost. And it's frustrating for the reps. They want to be on the road all the time, especially if they have to do overnights. That can be really challenging. And then the second problem is the touch points. So if the area is too large, then they're never really touching base with the primary referral partners because they're constantly traveling, they're constantly talking to new people. Outreach is all about relationship cultivation. It's not just like regular marketing in a digital campaign. We're not trying to get an ad in front of one person one time and then hoping that that person is going to be blown away from that one ad that they saw and then make a decision to use your healthcare services from there and out. It's generally not how these things work. So same thing with the outreach rep. We need them to be out in the community talking to people and talking to them multiple times because it takes multiple conversations to really differentiate yourself, build the relationship, help the community referral partner understand the value that you're bringing to the table, and for them to just grow in trust. As we keep coming back to, marketing is about building trust to drive a desired action. And we can't build trust if we've just met someone once for 15 minutes or had a coffee meet. We need to be coming back again and again. So we want to make sure that their focus is geographically restricted or restricted by the number of accounts that they're managing if they're assigned a bucket focus or a specialization in a particular kind of outreach. Specialization, when we think about it, we have our primary buckets that a lot of providers will have. Again, we're going to have adjacent partners in the community. We're going to have hospitals. We're going to have individual doctors or nurses that are practitioners. Maybe it's counselors. Anyone in the community that makes sense for us is generally going to be a broader focus. But we can have that focus in terms of like court systems or schools because it's such a different communication style and different needs and desires from those community members. What a school needs is very, very different from what a hospital needs, is very, very different from what an individual PCP or general practitioner needs. So if we can get someone that's really good and has experience in those areas, it can be very beneficial to do a specialization hire. Another example is something like unions. Unions are very, very hard to get into, but can be very attractive for a number of different healthcare service providers because they can form a direct relationship with the union. Or tribes is another one. So working with a lot of Native American tribes can be incredibly valuable because those are private relationships. Other things might be professional organizations, so like the FAA or the nursing board for the state. There's different reasons to build relationships that are very difficult to navigate often, very difficult to build. You really have to know that world. And so it's very valuable to hire someone that comes from that world and has that experience, and that's their sole or one of their primary focal points. Compensation is always a question that comes up here, and there's a lot of debate on it. Where I personally land on the debate in terms of commission-based compensation is generally we don't recommend it because you want people that really care about your mission and the patients, and they're happy to get a paycheck for doing something that they find personally meaningful and rewarding. That's really valuable. A lot of people look for these A-type sales individuals where they're very motivated by money and competition. And what can happen in those situations is either A, maybe they become frustrated because you need a team collaborative environment in healthcare a lot of the time, and they tend to be more of the lone wolf personality type. Or they cut a lot of corners, they don't represent you well because they come across more like a used car salesman, and they're always trying to, finagle the patient in the door or get the community partner to make the referral. That's not done in a way that represents you well as a healthcare provider that is focused on quality patient care. And so we're pretty hesitant about recommending a compensation structure. When we think about all the other roles in the company, do any of our other roles have a commission-based or performance-based bonus related to what they're performing in their role? And the answer is generally no, right? If the company's doing well, we might have a profit share. If that individual does a good job, they'll get good performance reviews and they'll get regular raises or percentage raises based on that, or they'll get promotions. And your community outreach should really be thought about in the same way. Also, as we'll talk about in the compliance unit or module, there's a lot of risk around having any kind of commission structure for an outreach role within healthcare due to the Care Support Act, STAR kickback laws, and there's just a general distaste for it sometimes in the healthcare community as well. So even if there are different ways to provide a commission structure, it can be completely legal, and many providers do this. But the challenge then is even the ethical side of it is, okay, well, are you paying for patients? How it can come across in the healthcare community, and that can have a negative impact on your referrals. The other reason that we really like to have a flat salary based on someone who really cares about it is, well, one, it's usually actually a little bit cheaper because that person is not there to maximize their paycheck. That person wants to be fairly compensated or well compensated for doing a good job, but for doing work that is meaningful for them. There's a better chance that they're going to stick around longer. So with the A-type reps, again, they're trying to maximize their personal revenue. So the second that someone offers them better revenue opportunity, they're going to jump ship. Healthcare outreach is really about building strong relationships and cultivating those relationships, and we have data on that. So we see consistently that reps that stay for consecutive years do 10 to 20% better each year that they're with the same provider, not in the same space, not staying in a particular service line, but with a particular provider or healthcare service. That organization, if they're with that for a long time, every year they do better and better and better. So you really want to get your hiring and your incentivization structure right to get people who are wanting to stay with you, because that is going to deliver the best value. And that makes sense, right? The longer you're connected to someone, you get to know the organization better, you get to know the community better, people trust you. The longer you've been with someone, if they see you not jumping around, if they see someone jumping around, it destroys a lot of trust. If a community outreach rep comes in and says, hey, the organization I'm working for is the absolute best at what they do, and then 3 months later, they're working for someone else and they come in, oh, well, this new group I'm with is the absolute best at what we do. They're starting to lose trust already in that process, and you want to avoid those kinds of situations. So really good reps, salary, compensation. You can obviously put bonuses and stuff in there tied to a number of performance metrics, but that should be similar to your other roles in terms of how they get bonuses or they get promotions, rather than having a specific compensation strategy for outreach roles from our perspective in terms of what we've seen work well with healthcare providers. You want to vary your touch point frequency based on let's say the value or the tier of the account. So if we know that the school systems provide us a lot of referrals, we should be having a lot of touch points there. And we should be having touch points with multiple members of that school system. So maybe it's with the teachers, maybe it's with guidance counselors, maybe it's with the administration, maybe it's with the PTAs. The stronger we can build holistic ties, the better and more successful we're going to be in terms of working with that particular partner. So really recommend maximizing the touch points and focusing more effort on the more valuable or effective accounts. And always from a strategic perspective, this is important. You should not be siloing your outreach team. I can't tell you how often that we see this. When I go into an organization, their outreach is over here, their service providers are here, the people providing the care, the marketing team's over here, and no one's talking to each other. That is a horrible way to run a team, because now the outreach team doesn't truly understand what you do well, unless you've got a robust training system in place, which is another area that a lot of providers lack. A lot of reps are just kind of pushed in the community and said, go, figure it out, and can you, start bringing in some referrals. you need to be connected to the clinical team because that helps you understand what is actually going on as a healthcare provider and what you do well and what you do different. And then, of course, being able to speak to a person and say, hey, look, I've seen how we provide services. I've seen how we deliver care to patients. That goes a long way to build trust with people. But then the marketing team has to be supporting that individual. It's not just collateral. It's not just providing a business card and making flyers or trifolds. You should have dedicated community outreach campaigns. So when you think of your television campaigns, those are supporting your outreach team. Because when providers, whether it's a discharge nurse at a hospital, whether it's a PCP, whether it's a teacher at a school, these individuals watch TV. And when they see that ad and then the rep comes knocking on their door, they go, oh yeah, I've heard of you guys before. I'm familiar with what you do. That makes sense. Yes, I'd be happy to set up a meeting. So it eases their ability to get their foot in the door, or it keeps them top of mind. You have a rep, how many people can they see in a day? 4, 5? I mean, tops, that's kind of your maximum. And so you're not able to reach a lot of people. You're not able to reach people all the time, every day, whereas you can spend advertising dollars on TV or Facebook or LinkedIn and get in front of people consistently for a very cheap cost, really supporting your business development team so that every touch point is not dependent on them doing a face-to-face meeting or a call. It's not as an effective use of your overall resources if you're not supporting your team by having paid media campaigns. Television is really good for community outreach if you're a large enough organization to start affording television campaigns. LinkedIn is fantastic. LinkedIn is a great outreach strategy and channel for B2B support and building additional community referrals. Other channels that are really good are things like ZocDoc or sometimes WebMD or Doxology. There's these different online service providers that have built networks of professionals working together that you can then advertise through in different ways to support your outreach team. All right, moving on to data. Data is really quite simple within the outreach. It is just qualified referrals. Qualified referrals is your primary metric in terms of evaluating, is your team doing well or are they not doing well? How many qualified referrals are we getting per rep? Now, if your rep's not bringing in qualified referrals, then you can dig into kind of your leading indicators or your activity or what we call output metrics. So are they doing enough in-person meetings? Are they doing tours of your program or your facility? Are they following up with emails, calls, video calls, etc.? You want to dig into that. But again, that's not the CEO's job. That is whoever leads the outreach team or whoever oversees the outreach team should be following up with those leading indicator KPIs if you have a rep that is not performing to expectations. But if they've got qualified referrals in, then you don't really have to worry about how many in-person meetings they're doing or how many emails they're doing. A lot of times we'll see that this is pretty heavily KPI'd. That can be useful for a new rep or an inexperienced rep and say, look, if you do 5 in-person meetings a day, that's going to increase the probability that you're going to be successful in this role over time. Great thing to tell someone just starting off in the role. But really good reps know what they're doing and they're able to organize and adjust their time and their touch points to meet the needs of different referral partners. Some referral partners really value in-person meetings and those are easy to schedule. Other referral partners are happy with just an email or a phone call, and a good rep will start to understand the communication preferences of the community referral partners and adjust appropriately. So when you KPI the output or the activity of the rep, then it often has them doing things that might not be so productive once they've become good at what they do. Again, for individual reps that are newer or at least newer to your organization, there can be value there, but we don't recommend KPIing those as much as qualified referrals. And again, that allows the reps to be more creative too. Let's say we want 10 qualified referrals a week. How are you going to get that? Is it more in-person meetings? Is it more calls? We don't really care how you organize your time as long as you're able to be effective with your time in generating that volume of referrals. So KPI them on the qualified referrals. And that there should be some kind of accountability around CRM updates. because you absolutely want to be able to check on their activity. One, it's just a little bit of accountability there, but really more importantly, it's about organizing their time so they can see where they went, what's working, what's not working, what was the last conversation they had, how many times they've talked with this particular community referral partner before. And if the individual leaves, you want a record of all that information so that the next person can just step in, read through the notes, understand what the activity looked like, where the referrals were coming from, what the conversations were, and then pick up where that individual left off. So CRMs are really, really important. They help the rep do their job better. They help you organize the work, and they help long-term for people that are switching positions. So there absolutely should be some kind of accountability around CRM updates. Now, notice again here, like we keep saying, or I keep saying, there is no focus on new patients or admissions. That is the job of whoever is handling the call to get patients scheduled for an assessment or to start the program or to start services. When you KPI a rep on the new patient, then they get all mixed up in that, and they're, instead of going out into the community and building and cultivating relationships, they are on the phone or in the CRM checking to see what's going on with this patient they referred. Did they get in? Did they not get in? Have they been scheduled? Have they not been scheduled? And it's really frustrating for the call team or the front office desk person to be managing this. So now you're wasting two people's time. You want to avoid that by not KPIing them on new patient assessments, admissions, whatever your criteria is for, basically a paying patient. Get them focused on qualified referrals, and then they're moving on to the next one. They and you have to trust the admissions team or the new patient team or the front office desk to do their jobs and do it well, and they're KPI'd on the conversion rate there. So that's how you should be managing that situation. Now, another thing that we see so often is this obsession around final attribution that we've talked about in other modules. You really need to get away from, because there is rarely a single touch point with a new patient coming into a program. It's very rarely the case that it was just the work of that business development rep. As I just spoke about when we talked about supporting the team, you should be having LinkedIn campaigns. You should be having, if you're a big enough organization, television support campaigns. You should be running Facebook and SEO. These things are going to benefit the outreach team and be additional touch points. It's very likely that a patient has seen a Facebook ad, their provider that's referring them saw a LinkedIn ad, and also had a conversation with your rep. So we've got three separate touch points, very, very common patient journey. So who touched it last is largely irrelevant. All you care about is that the patient is getting connected to quality care. Do we really care what that journey was to assign it to a person? It's just a bunch of nonsense, and it leads to a ton of infighting. So where we see the fights happen most of the time is we'll see something like an outreach rep owns a particular account. And so let's say that this hospital provides a referral, but then the individual called from a Google number. So instead of calling the rep, they did an online search and ended up calling off of a Google ad. And so now there's this conflict between the internal marketing team or external vendor and the outreach rep about who got the referral or the new patient. Again, a bunch of nonsense. If the Google ad hadn't been there, they might have not found the number. If the community outreach rep hadn't built a relationship with that individual, that organization, they might have never thought to call. These things work together. So the simplest way to do this is, when you identify a multi-touch, if you're really focused on attribution about who goes where, you just give credit to each team and you give them full credit. You say, great, okay, we identified that this was multi-touch. You both get credit for that qualified referral or that new patient. Keep it simple, get rid of the conflict, and just have people focus on doing their jobs of connecting people to your quality care. Last thing that comes up a lot of the time is house accounts. Sometimes people are a little bit reluctant to, again, assign credit for a house account because it's like, well, we've had this account forever. They've been working with us and referring us for a long time. And this individual is just coming in and taking it over. Very understandable, very logical. What we've seen pretty consistently, though, is those house accounts need to be continually cultivated or they will eventually stop referring. Maybe that's because the relationship gets distant. Maybe that's because there was turnover and the relationship you had isn't maintained because the main person referring to you is no longer at that organization. There's lots of reasons that you need to maintain connection and effort with a house account or established relationship. And so again, when we've seen people pulled off of those because, hey, they've been referring to us for 5 years, they'll keep doing that. It does drop off if no one's actively cultivating that relationship. So this is another situation where just give them the credit for it, regardless of whether it was a house account or not, because it has value and it's not going to work if they don't. Now you should be thinking about like who gets the house account. Like you want the people that are your best reps and your best reputation of you. So if you have a lot of people, then you want to think strategically about who gets what. And normally within any kind of referral environment or a sales environment, the better reps are going to get the better accounts because they're just better at their jobs. And you don't want to lose that account. You don't want to lose that relationship. And a newer individual or less experienced or just a less successful individual is not going to be able to do that as well. So give your house accounts to your best staff. That should be part of your thinking when you're doing a territory analysis. Again, geography or specialization makes sense, but you also have to have these other considerations that are coming into play. Moving on to tactics. First place to start is tiers. Generally, you have an outreach strategy that is focused on your top tier accounts, which are the community partners that refer the most, second tier, third tier. And the 2 points to think about with them is one, the top tier accounts get the most attention. So you should be spending the most effort with those. Second, third, obviously following that. And then your top reps should also be getting the top tier accounts if you have any kind of two reps in a similar territory or focus. So pretty simple, but important to have that tiered structure in there for all of your accounts. Event attendance, thinking about local events, whether that's a health fair or a conference or even attending a PTA function for a local school, whatever the situation is, you want to be attending events in your community. You should be doing those on a regular basis, in addition to your standard outreach of walking in, talking to people, setting up meetings, setting up calls, following up with emails, etc. Event attendance is really important to be part of the community. And how do you think about those? Often that's a big question mark for a lot of providers. Do we pay $500 to have a booth at this event, or do we just send someone? Do we pay $1,000 to sponsor that event, or do we just have a booth? And you really want to think about it from your standard marketing lens, which is your CPM basis. How many people are going to be there and will you be able to get in front of? And then are those people the right people in terms of either referring to you or as potential patients? So if the more targeted they are, the more likely they are to be your patients or community referral partners, then that's a higher value. And also the more people that are going to be there and the more people you have an opportunity to interact with is, again, a higher value. So that's how you want to think about event attendance. And that'll also allow you to think about what the budget is that you want to provide for those kind of events. Instead of just attending events, you also want to make sure that you are organizing your own events. This is open houses, lunch and learns, CEU events for continuing education credits. This is a really important one for a lot of healthcare providers. You can also organize your own community health fairs or conferences, though those are pretty big lifts and can be pretty expensive, both from a labor and just an overall setup cost standpoint. But strongly encourage a really clear strategy around organizing events rather than just always attending, because that gets a lot of people into one place. It positions you a bit more as a leader within the community, or at least your reps as people that seem to have expertise around bringing the right people together. So really important to be thinking through those components of the strategy. Collateral is an important tactic that doesn't get a lot of attention. So your standard outreach reps will have their business card, they'll have a flyer or a trifold, and that tends to be about it. There's a lot more that goes into collateral that your reps should be thinking about and reporting back to the marketing team. Again, we want collaboration between marketing and outreach, and that should be determined by what are the types of collateral that referral partners use. So when we're doing outreach training, for example, we'll do ride-alongs with the reps. And so I will go and talk to a community partner, and we immediately, when we walk in the room, we look and see how their information is displayed or organized. Do they have a cork board? Do they have a file desk? If it's a cork board, how are things put up on the cork board? Are they using a bunch of little rack cards? Do they just have a list that they write down on? Do they pin up flyers? What is the information that's important to that individual or that organization? And do we have the right information to match? And we should always be talking to referral partners about this content. What are you looking for? Oh, it's nice for me to have the phone number, types of care, and insurance is taken, right in front of me. That's really useful for me. Great. Does our flyer or rec card have that? Yes or no? We should talk to marketing, get that, and provide it to that particular referral partner. It's just important for us to be thinking through strategically about what materials they need. And then going above and beyond that, do we have PowerPoints that we can provide people? Do we have white papers? Do we have studies, outcomes data, stuff that's really valuable for people that they're going to take some time, actually spend time with? Do we have things like a calendar we could leave behind with? Maybe it has little inspirational quotes, or maybe it has information on different clinical treatments. Something that's in front of them all the time is also really valuable and worth investing in for the right community referral partners. So get creative, think strategically, and even sometimes something as simple as a pen actually makes sense. Do you see that this individual loses pens a lot of the time and goes through a lot of pens? Then give them a nice pen and have them keep it. And that helps to be a reminder, in addition to providing more information on services through a white paper or a trifold or some other kind of information. Discretionary budgets is a question that we get asked a lot when we're talking about outreach reps. Should we give them $100 a month, $500 a month, and for what? Usually when you're thinking about your reps, most of your budget is going to be provided from the department level in terms of overall marketing budget or outreach budget. And so your flyers, your trifolds, your white paper printing costs should come from that budget. And that's going to be a big part of the discretionary spending. And of course, you're going to have travel costs. And then a big one comes down to food. So oftentimes there is question marks around, do we provide food for people? Is that okay to do, especially if we're taking Medicaid or any other kind of federally funded assistance? You have to be careful around there. You should always talk to compliance and legal counsels for those kind of situations. If you're not taking federal funding, it's usually a bit easier. You don't have those concerns as much. But paying for lunch is generally a good way to connect with people, whether you're running an event or just meeting up with someone. Now that's different though, because you get to spend time with that person, sit down with them. Having a meal is a good opportunity for your outreach reps to take more time and connect. Whereas bringing in food, like maybe you're coming in, they bring in a what we call a donut drop, a box of donuts or a box of cookies. That's a much bigger question mark and something that we generally discourage. I'm not a huge fan. I mean, think about someone coming into your office that you don't know. Do you really care if they bring a box of cookies or not? And does that communicate to you that they're really focused on patient care and how you guys are going to collaborate? Most healthcare providers and community referral partners are focused on the patients. They want to know, how can I help my patients better or do my job better? And so donuts and cookies don't really drive that outcome. It's just as easy to have a conversation, say, I want to sit down, go through what's been happening with you guys, what's happening with us, see how we can make sure that we're helping patients together. That should be the crux of every single conversation that your reps are having. We don't need to, what I consider sometimes to be, to cheapen it by saying, hey, look, I brought you donuts, so can I have a minute of your time? We really should be saying, hey, look, we're both working together trying to help out patients, and so why don't we figure out ways to do that or talk through ways we've been working together and see if we can improve on it. That's the real conversations that we want to be having. So it's a question mark of if you really need large discretionary budgets, and our response would be generally no. For most healthcare providers, you don't need too much. They should have something. You want them to be able to, again, go to lunch, take people to lunch, provide coffee, if they're going to have a conversation with someone for a while, but you don't need to have these budgets where you're doing 5 donut drops a day. So just mention the swag and the food there. You can bring pens, you can bring little stress balls, you can bring bigger things like calendars, you can bring really nice things like folders for them to organize files in. And there's a lot of different kinds of materials you can provide people. You just want to think, is it memorable? And does it communicate something about us that's relevant? So the stress balls that people don't really use anymore are a good example just because it connects to a lot of healthcare, right? We got stress, We want people to be healthy, and so here's a stress ball. This makes sense. Sometimes you'll see people use like USB drives. That can be a good one just because it's something that a lot of people carry around. So it's a good reminder. Maybe you can load it with files, and you can have a white paper on there. You can have an outcome study on there. You can have contact information preloaded on those. So that can be helpful in addition to being a reminder for individuals. And we talked about the food already. Really good idea to go to lunch with people or potentially provide lunch if you're having a larger event like an open house or a lunch and learn. Not as huge of a fan for the donut drops because it doesn't communicate necessarily what we want it to be communicating. Psychology of outreach is pretty simple, right? Just how do you want to be approached? If you've got someone that's coming into your organization wants to talk to you about potentially working together, collaborating, and referring to another provider, what would you want them to talk about? How do you want them to approach you? It's the same thing. So we are cultivating and developing relationships within the outreach space. We need to get to understand people, just like we're doing in marketing in general. What are their pain points? What are their needs? What are their desires? How can the organization that I'm representing best help that individual? And then how do we get to know each other over time so that we know, like, and trust each other? Relationship cultivation is critical to the success of the outreach reps. And that's why, as I mentioned earlier, you'll see reps that have been with an organization longer do better and better year over year because they've built more, deeper, and stronger relationships with the community referral partners over time. You have to be able to differentiate. So again, put yourself in the community partner shoes. You've got 5 reps that are coming to you. They're all for the same type of service. So why would I refer to this one versus that one versus that one? Your reps have to be able to communicate the differentiation, and they have to be able to do it with conviction and with expertise. So this is where the training components come in. This is where the connection to the healthcare service provision team is really important so they can speak to it intelligently. They have to be able to know what is different about you versus other healthcare providers in the community so that they can accurately represent you and accurately communicate to community referral partners why they should refer to you specifically versus somewhere else. Get to know the community partner. That's part of the relationship cultivation. What do they need? Is it a hospital that's really focused on throughput? Are they really focused on speed? Then you need to be, as an organization, set up to be insanely responsive. Are you on top of the faxes? Are you always answering your phone when somebody calls? Are you very quick with paperwork? Is that the need that they have? Or maybe they need really clear communication around referrals. So you have your ROI in place and they want to make sure, did the patient get into care? How are they doing with services? Have they completed care? How is that going? Any kind of information that's important to that community partner should be what your outreach team is focused on, and any support mechanisms within the organization to make sure that the community partner gets what they need. Related to that, you want to remove friction or extra work. So a real good example that I like to use is hospitals. Hospitals have a lot of Medicaid patients. And it's really annoying for a hospital discharge coordinator, discharge nurse, social worker to have to sort through, think through, or call multiple different providers to see if they take the individual's insurance. Oftentimes, a lot of healthcare service providers only take commercial insurance, only take certain kinds of insurance, maybe they're private pay, and that can be really, really frustrating for a hospital discharge professional. The easiest way to help that professional is to just help them with all of it. So even if you don't take Medicaid, for example, you should still be willing to take that call and help that patient get placed into a provider that does, or give them the resources they need, or whatever the case may be. So you're making that professional's job easier. Then instead of them having to think through and say, okay, well, who would I call for this? Who would I call for this? They have a one-stop shop and say, okay, I'm always calling Johnny. Johnny, whether they help out the patient and pull them into their services or refer them to another provider that takes the insurance or takes the situation for that patient, I know that Johnny's got it covered. I'm going to call Johnny. That's removing friction. That's doing the extra work that's needed to develop that relationship and make sure that you are the go-to provider and the person they're calling versus someone else. So FAQs on community outreach, how should we compensate our outreach reps? This I've talked about quite a bit already. Strongly recommend against doing a commission-based structure. There's ethical questions there. There's definitely legal compliance issues for a lot of providers in the healthcare space about any kind of qualified referral or new patient commission structure. And at the end of the day, we're generally not looking for A-type salespeople within the healthcare space. We're generally looking for people that are collaborative, supportive, mission-driven. That lowers our costs, it lowers compliance and legal risks, and it generally leads to longer-term success with individuals in that role. It's a choice that you have to make. There are many ways to build in commission structures through point systems and other convoluted mechanisms that allow you to legally provide some kind of commission, even if it's not a direct commission for patient to commission kind of linear relationship. You can do it through these convoluted point structures. Don't recommend it. Keep it simple. Just focus on finding the right people like you do in every other role in the organization. Should they have a discretionary budget? Just talked about this. Most of the time, yes, so they should have some kind of discretionary budget, and it should generally be related to the amount of lunches or meetings that they're going to have to go to. Anything after that should generally be a question that goes up to the department head for approval. That might be conference attendance or event sponsorship or something like that. The main question that we think about is, do you need the money for the donut drops or the cookie drops all the time? Our answer is no. It doesn't really communicate what we want it to communicate. It is something you can have in there. It gets more expensive if you do that. Makes it a little bit easier for the reps because they feel more comfortable having something that they're coming with. But again, if you really get mission-driven reps and you redirect them to think about adding value and how you're helping community partners, they'll generally start thinking in that direction about having the right conversations with the right people. And then they'll realize that they don't need the donuts or the cookies or whatever it is anymore either. Just a funny question. Sometimes we get this, or sometimes we don't get it, and maybe they should be asking, how do we know that they're not just at home watching TV? The simple answer here is obviously if they're not putting notes in the CRM, and if you're not seeing referrals come from that individual, then something's not working. Either they need support and training or better marketing support overall, or they're just not good in their role. They're not doing the job. Could be one of those things. So it doesn't really matter like where they are. You just know that they're not performing at the level that you need them to perform at. And so you're going to engage that process and look for extra accountability, provide extra training if needed. But it comes through in the numbers and it comes through in the CRM. It's pretty easy to watch and see, so we don't really worry about it. On the other side, we have come across reps that just have some key relationships that they've built over time. They're really good at it. And so maybe you're looking for them to get 10 qualified referrals a week, and they're doing that on a regular basis. Do we really care if they are not putting in a full 40 hours a week, if they're hitting the metrics we're asking them to hit? Obviously, in an ideal world, yes, we want them to be going out and putting in that amount of time because they have it and we're paying them for it. But at the same time, it's hard to find good reps. It's hard to find reps that meet the metrics that we're putting in place for them. So generally, I often say if they're hitting the numbers, then follow up, talk to them, see what's going on. But we're getting the results that we want and need at the time, and so we should probably be thankful and happy for that component and not overly worry about where they're putting every minute of their day. How many do we need is a really common question. And obviously it comes down to your territory analysis. What are the total potential referrals from a given area? And how many touch points, how often do we have to be meeting with and talking to those people? So if I've got 500 potential referral partners in our community across hospitals, schools, adjacent healthcare providers, nonprofits, whatever, there's no way one rep could handle all of that and have the touch points needed to build and cultivate a relationship there. So then we're going to want to look at either shrinking the territory or assigning buckets for outreach, some kind of method where we have a territory analysis that determines the volume that we need. And we should have benchmarks around what our average reps are able to do. So when we look at our historical data, or we can benchmark it across the space, just talk to another provider in another city or someone that's not a direct competitor and say, well, how generally do you see, or what do you see your reps doing in this space? That gives you your benchmark if you don't have historical data. Or you can talk to an agency like us. We generally have a lot of data on information like how many reps different service types use. And we can provide that, and then that gives you a sense of where you're going, how many reps you're going to need in total. But it's pretty simple math most of the time. And then obviously you have your calculation around how many admissions you need. Most providers will see 50% plus of their admissions coming from some kind of community referral source for most healthcare provider types. Reps want to attend a conference. Do we approve it? This question comes up all the time. Same answer I just gave on the previous slide. You just want to understand it from the CPM basis. How many people are they going to see? How relevant are the people that are attending this event to you as either community referral partners or people actually seeking your services? If that aligns from a cost and a focus perspective in terms of your target audience, then pay for it. If it doesn't, then don't. Just keep it simple. You're not trying to tie this direct ROI to an event attendance because it's usually not possible. Just think about it from a CPM standpoint in terms of your target market. Another question we get asked in some service lines, especially some of the higher cost ones where they're doing like private pay clienteles for a surgery or some kind of wellness treatment. Can we hire someone who already has a book of business? The answer is usually no. Not saying that it doesn't work. There's obviously potential for someone to be having a really good reputation that moves to a new organization and then all their relationships come with them. Most of the time, this doesn't work though. What we see across our aggregate data consistently is, again, the same rep working for the same organization, not in the same vertical, not for the same service line, in the same organization, does better year over year because of the trust and the relationships that are built. If you've built really good relationships and you bounce from place to place to place, those relationships fray over time. Because again, I can't trust someone if they tell me that this place is the best to send someone, and then they tell me somewhere different 3 months from now, somewhere different a year from now. That trust erodes. So that's not valuable to be moving books of business around. Now, if you've had someone that worked in the field for 10 years with a particular provider, and that individual really believes that you're better for some reason, or maybe it's a slightly adjacent service line where those community referral partners still make sense, and so there's a shift in focus, that can be a really, really good hire if the person's willing to make the move. But what you don't want is, these people that tell you they have a book of business and they're bouncing from provider to provider. If you see that every year or less that they're changing their employer, that's a sign that nothing's going to come from that. Also, just keep in mind that often service levels or focuses don't translate. So let's say that you have someone that's really good working for a Medicaid provider. They're not going to be a good fit, or at least be able to move a book of business from Medicaid to commercial or vice versa. Same thing if someone's working in let's say someone's working in the bariatric surgery space and then suddenly move into the hospital systems. Like, that's not going to translate. There's not going to be a lot of business relationships that move with them. Now, there's experience, there's expertise that they can bring to the table to build up the new relationships that they'll need to build, but they won't necessarily bring a book of business with them. So that's how we generally recommend that people think about that question. Last and obviously important question for everyone is, when should we expect results? This completely depends on the service line that you are providing and a lot of factors like competition. Is it a new market? Are you an established provider, et cetera, et cetera? But in general, you want to think about it from building relationships. You have to build relationships. Those generally take anywhere from 2 to 4 months to really start getting strong enough for people to send referrals. Especially if it's a highly competitive space, you've got to give your rep the tools to differentiate so that they know how to communicate with community referral partners, especially if you're moving into a new market where there's established competition. You're going to have to give them the tools, the resources, the training to be successful, and hopefully the supportive marketing campaigns that helps get their foot in the door. So results are highly variable. It's really, really hard to give a number because it's so variable depending on all these factors. But on average, we'd say 3 to 4 months. We want most reps and most service lines to at least be covering their own cost in terms of labor and any discretionary budgets you're providing them. But it always takes time. It's never have someone come with a book of business and they're successful from day one. That's almost never happens. That's it. That's our overview for community outreach. See you on the next one.